Hello all, welcome to the second session of antidepressant drug. In last session, we have discussed about what is depression and the drugs, typical antidepressant like monoamine inhibitors, tricyclic antidepressant, serotonin norepinephrine reuptake inhibitor, and those which are nowadays known as a first-line drug for a treatment of depression is a selective serotonin reuptake inhibitors. In today's session, we discussed about the atypical antidepressant and the therapeutic uses of antidepressant. Atypical antidepressant, they are not as like as an typical drugs like SSRI and SNRI. So their action is not on a reuptake mechanism, but they work by different mechanism, and that is why they are known as an atypical antidepressant. The first congener is Nafazodone. It is first atypical antidepressant. It has a prominent adrenergic and weak 5-HT2 receptor antagonistic action, as well as its metabolite is also strong 5-HT2 blocker. So being a alpha blocker as well as a weak 5-HT2 blocker, it it doesn't produce a action as like as SSRI and SNRI. It is sedative, but there is a no any anticholinergic side effects like produce. It causes bradycardia, so does not interfere with the intracardiac conduction, and thereby it is less prone to causes a arrhythmia. So it is different than the SSRI and SNRI. When it is administered, it also produces adverse drug reaction. When one of the common adverse drug reaction is produce sedation, it will also produce prolonged and painful penile reaction occur resulting in impotence. That reaction is mainly because of alpha-1 adrenergic blocking property, as well as this alpha-1 blocking property also produces a postural hypotension. So Trazodone is infrequently used for a treatment of depression unless it is associated with insomnia. So if insomnia is associated, being it having sedative property, it is helpful for those patients. Second one is Mianserin. It blocks the presynaptic alpha-2 receptor. So it is what we can say that it blocks the alpha-2 receptor. Here you can see that these are the alpha-2 receptors which are present at a presynaptic level. So it increases a release of norepinephrine in the brain, which may be responsible for this antidepressant action. It also produces antagonistic action at 5-HT2 as well as a 5-HT1C receptor. It also blocks histaminic receptor. So by having antagonistic action at a multiple receptor and increased norepinephrine level, it is helpful to relieve symptoms of depression. So it is sedative, so relieve associated anxiety, as well as it can also suppress the panic attack. Being a atypical antidepressant drug, it produces some adverse drug reaction in the overdose. That what we can say that it augment the seizure attack. So the seizure threshold is lowered with the Mianserin. So person who are having a tendency to develop epilepsy, by use of Mianserin, it can aggravate that. And additionally, it suppresses the bone marrow, and bone marrow suppression may lead to development of various blood dyscrasis. And due to this adverse drug reaction, the use of Mianserin is restricted. Third one is Mitrazapine. It is act by blocking alpha-2 autoreceptor. Here you can see that this is the Mitrazapine, which block the alpha-2 receptor on noradrenergic receptor. These receptors will be blocked, and it can also block the heteroreceptors which were present on a serotonergic neuron. So auto as well as heteroreceptor on both the neuron, noradrenergic neuron as well as the serotonergic neuron. Both autoreceptors were suppressed with the metrazapine. So, by separation of that autoreceptor, may inhibit the feedback mechanism, and it can enhance the both noradrenaline as well as the 5-HT release. So both the release were increased with the metrazapine. It also produces selective enhancement of antidepressive 5-HT1 receptor action. That action is basically achieved by blockage of other serotonergic receptor like 5-HT2 and 5-HT3 receptor. So by blocking this receptor, we can say that there more profound action is generated on a 5-HT1 receptor. So if adverse drug reactions which are produced because of 5-HT2 and 5-HT3 receptors, those cannot be produced with the metrazapine. So it has been labeled as an uh, noradrenergic and specific serotonergic antidepressant drug. It has a minimal sexual side effect, which is in comparison where SSRI having more sexual side effect, which are not produced with this one. Other adverse drug reactions which are associated like sedation, weight gain, and lipid abnormalities. Another one is bupropion. It inhibits noradrenaline and dopamine uptake and produce excitation. It is metabolized into an amphetamine-like compound and which also causes a presynaptic release of dopamine and norepinephrine. So, in short, the action is uh, uptake is also inhibited as well as it can also enhance the release of those neurotransmitter. So excitatory effect can be generated when sustained release formulation is specifically used for the smoking cessation. So for smoking cessation, sustained release formulation is used where bupropion may be acting by uh, augmenting the dopaminergic reward function, and when we can say that when we want a better result that can be obtained, it is when it is combined with the nicotinic patch. So the nicotine withdrawal symptoms were less severe when bupropion added with the therapy, but still we cannot say the long term efficacy of this compound. One of the drawback is it can also lower the seizure threshold, so it can precipitate the seizures at a higher doses, and this is the main drawback of bupropion. And the last one, Nafazodone, it blocks serotonin reuptake and antagonize the 5-HT2 receptor. So these receptors will be blocked with the Nafazodone, and it also lack the anticholinergic effect which are as like as a tricyclic antidepressant and the other effect like agitation which is seen with the SSRI. So those drawbacks of tricyclic antidepressant and SSRI, they cannot be observed with the Nafazodone. It has a very short half-life and may sometimes produce some hepatotoxic effect. So these are the different atypical congener, what are their primary mechanism of action and the adverse drug reaction produced. Now move on to the therapeutic application of those congener. As these are the drugs, all antidepressant drug having some action at different CNS disorder as well as they also having some known CNS disorder. Their action is on a known CNS disorder. One of the important is endogenous depression. There are, when we can say that for the treatment of depression, there are three types of treatment for a depression. One is psychotherapy, another one is pharmacotherapy, and third one is electroconvulsive therapy. Pharmacotherapy, when it is administered with the specific group of drug, its antidepressant effect is achieved. Almost 70% of depressed patients may produce a beneficial effect. So when we can see that for a treatment of endogenous depression, our goal for treatment is in acute phase is to resolve the symptoms, in continuation phase to prevent the relapse, while in case of maintenance phase to prevent the recurrence. So with this goal in our mind, we can go for drug selection. The drug selection primarily we can go for a SSRI, metrazepam, nafazodone or valnafexine. These are the highlighted drugs, or we can say that they are the drug of choice for a depression, but the first choice as per the tolerability and the safety criteria. And out of all this, SSRI are known as the first drug of choice for their better tolerability, safety, as well as their higher efficacy. So almost all criteria were fulfilled with the SSRI. So SSRI nowadays are the first line drug for a treatment of endogenous depression. Now we may having a question that how long the therapy is administered. So sometime if symptoms were not resolved, we have to change over to another group of drug, or when the person is completely recovered, we have to stop the antidepressant therapy. So how it can be done? Changing and stopping the antidepressant drug. If required, it should be crossed tapered, where the dose of new drug should be gradually increased and that of other drug which we want to stop it, there must be decreased in a gradual manner. So it is always in a cross tapering manner. After a depressive episode has been controlled, continued treatment at maintenance doses for a month is recommended to prevent development of relapses. And discontinuation of antidepressant drug may be attempted after 6 to 12 months of therapy. So, once the episodes are controlled, treatment should be continued for maintenance doses for months, and after 6 to 12 months, we can gradually stop the administration of therapy. But if the person is high risk patient, a 3-year or more continuation therapy is needed for protection from the recurrence. When stopping the drug, the dose should be tapered over a period of. Second one is obsessive-compulsive disorder. The SSRI, particularly the fluoxamine, is the drug of choice due to its better patient acceptability. There are some other drugs like clomipramine, which is from tricyclic antidepressant, is also highly effective in OCD. When we can say that SSRI and tricyclic antidepressant both can helpful for obsessive compulsive disorder in other OCD like compulsive eating in a bulimia. It also helpful in a patient with the dysmorphic disorder. It is a mental illness which is involved obsessive focus on the perceived flow in the appearance, and others like compulsive buying and the kleptomania, which is uncontrolled desire to steal the things. So mania OCD where using of tricyclic antidepressant or SSRI may resolve the symptoms, but the habit of some OCD may not completely die. Third one is anxiety disorder and depression, especially SSRI and SNRI. Both can exert a delayed but sustained beneficial effect in many patients of social anxiety and generalized anxiety. They are also used uh, for a short period of time in case of what we can say that for a phobic disorder where SSRI and SNRI both can be administered. They are also helpful for a post-traumatic stress disorder. This is a condition that any after a traumatic condition person may having stress anxiety disorder. For that SSRI and SNRI both are helpful. And another indication of in anxiety disorder is that menopausal women likely to get a mood swings and hot flashes, and that can be controlled by using SSRI when particularly when the hormone replacement therapy is contraindicated, and to control a symptom SSRI are helpful. Then the indication in neuropathic pain, amitriptyline and other tricyclic antidepressant can produce a considerable relief in diabetic and any other type of chronic pain. Then they are indicated on attention deficit hyperactive disorder ADHD, and specifically this condition is observed in the children where they cannot be concentrated on a one particular thing. So for that, tricyclic antidepressant with less depression property like imipramine, nortriptyline, and amoxicillin are now first-line drug in this disorder, which is incomparable in efficacy to an amphetamine-like drug, with the advantage of less fluctuating action and a few behavioral side effects. So their efficacy is as like as amphetamine is also one of the drug for a treatment of attention deficit hyperactive disorder. Other indication is smoking cessation. Only bupropion is approved as an aid to smoking cessation, though the some tricyclic antidepressants have also been found to reduce craving symptoms. When bupropion is administered, abstaining subjects who are on a bupropion experience a fewer distress symptoms and a mood swing. Then they are indicated for Enuresis. In a children above of 5 years age, imipramine 25 mg at bedtime is effective, but bedwetting may again start when the drug is stopped. It is also effective in elderly subjects with the bedwetting problem. Other indication is migraine. Amitriptyline, which has some prophylactic value, especially in a patient with the mixed headache disorder. And lastly, they are indicated for a condition like pruritus. Some tricyclic antidepressants produce an antipruritic action, and for that, topical doxepin has been used to relieve itching in atopic dermatitis. So here you can see that there are list of indication which are where the different antidepressant drugs are used. So in a summary, we can say that atypical antidepressant act by a different mechanisms, and the selection of antidepressant depends on the patient's suitability and tolerability. So if we want to remember the uses or the indication of antidepressant drug, it can be memorized as it is used for depression, it is used for enuresis, where the drug of choice is imipramine, it is used for phobia, used for a recurrent panic disorder, it is used for eating disorder, bulimia, smoking cessation, bupropion is the drug of choice, stress disorder, post-traumatic condition, then impulse disorder, kleptomania, to steal the things, and obsessive compulsive disorder, and lastly they are used for a neuropathic pain. So here you can remember the depression, and on the basis of that, these are the many different indication of antidepressant drugs. So this is all about the depression and antidepressant drugs. Thank you.